So hello everyone, my name's Lan, I'm one of the Orthopaedic registrars, and today I'll be presenting our results from COVID-19 Boast guidance looking at outpatient management. So as we know, the new guidance had come into play on the 22nd of March this year, and its imperative was to minimize operative trauma and minimize hospital attendance to adapt a more conservative approach to managing acute conditions. We looked at 4 key standards, the first being immobilisation. So we aimed for 100% of cases meeting removable cast or splinting. The second audit standard was looking at index face-to-face appointments and ensuring that all patients were virtually screened. The third standard looked at follow-up appointments, which should be conducted virtually by phone or video. And fourth standard was repeat radiographs looking for union, which should not be conducted in any of the cases. In terms of our methodology, we adopted a prospective data collection over the course of 4 weeks, which allowed for a 2-week adjustment period, looking specifically at virtual fracture clinics and Cascade. 223 patients met the inclusion criteria. So in terms of our results and our first standards, 100% of patients had a removable cast or splint. So clearly the message had filtered to A&E. However, 5 patients had inappropriate forms of immobilization that needed revision. In terms of the second standard, 96% of patients had been virtualed or triaged by the admitting on-call department, of which 4% of patients had slipped through the net and had their initial index appointment face-to-face rather than virtually. In terms of the follow-up appointment, 97% of patients were virtualed or had documented clinical indication for re-attending to clinic. So 16 patients had face-to-face follow-up appointments, of which 6 patients had no formal reasoning as to why they were brought back. Looking at union, only 0.4% of patients had inappropriate radiographs screening for union, of which 1 had absolutely no risk factor profile. So in summary, we achieved a fairly good collective with a 97% achievement record across all standards assessed by the audit. However, there was still room for improvement. We administered our re-audit, and over the course of 2 weeks, we identified 145 patients meeting the inclusion criteria. Again, we identified 100% of patients and we maintained that consistency for patients who were immobilized in cast or splint. In terms of the second standard, we noticed a marked improvement with all index appointments been triaged virtually or via the on-call team. And the 1 patient that slipped through the net was referred by the GP. We have since amended our processes to include all GP referrals as well as tertiary center referrals to be triaged virtually prior to arrival into hospital. And in terms of our follow-up appointments, 100% of patients met the VFC or senior clinician triage service prior to attending clinic, and only 1 patient had no formal clinical indication for documentation by being brought back into hospital for a repeat radiograph at 6 weeks. So to conclude, consultant initial decisions via VFC helps to streamline our orthopaedic service. The virtual fracture clinic has far-reaching implications post-COVID-19 pandemic and can greatly reduce the economic burden for the NHS. Any questions?